All right. So I'm Randy Olson, Chair of Ophthalmology here at the University of Utah and CEO of the Moran Eye Center. And it's an honor to talk to you today about a major disease, a major burden we all have, and some of the innovative things that we're going to do to address the problem of glaucoma. Glaucoma, interestingly, is a problem that most people don't realize they have. But when they do, they wish they had and known more about it. We call it the silent thief of sight, and we're going to give you a little tutorial about it before we get going on with what we're going to do. So let's see, there we go. We want to point out that the Moran Eye Center represents an incredible combination of great science, teaching, and clinical care. And we've had a lot of national and international recognition of late of the great work that's ongoing here. And I can't thank the team enough for all that they do to make this such a special place. And the recognition and I think just shows that indeed this impact is being felt both nationally and internationally, and could not be possible without all the amazing team, the almost 70 faculty and over 500 staff that make this place work. All right. Told you, silent thief. So what are we talking about? So you're looking at the back of two different human eyes here, and you can see on your left-hand side that kind of a hazy, lightish, not exactly white circle. That's the nerve that leaves the back of the eye. Now, even though the eye is the one that we perceive as seeing, the final vision actually happens in the brain. And it's the brain in the back of your head, believe it or not. So the eye, though, is the one that processes all these signals, and all of that have to go through a little nerve that's coming out of the back of the eye. This nerve is only about 1.5 millimeters. That's about a 1/16 of an inch in diameter. And in order to have the miracle of sight, it takes 6 million nerves to do this. Can you imagine? We're talking literally trillions of chemical reactions that are occurring every minute just in order to have the miracle of vision. So if you notice the one that says glaucoma, there's something funny about it. Can you see that? There's this big white area that we call the excavation of the optic nerve cup. We all have a little cup, or almost all of us do, but this one's a very large cup. What is going on here? Well, it's because those nerves have largely died off. And in this particular case, by the size of that cup, you've probably seen 80% of those nerves already dead. Now, here's the problem. You lose an optic nerve, even a single one, you never get it back. We do not know how to regenerate that or come in place. So this is a process of determining those who have glaucoma and stopping the onslaught. We can't get it back, but our whole goal is to catch it early enough that people do not have significant problem as far as their ability to see. Now, even though I told you that this was a problem of death of the optic nerve, we don't know enough yet at this point, although there's some interesting work ongoing we'll talk about a little bit later, of how we can prevent that. But we do know that it closely correlates with the pressure inside of the eye. Now, think about it. The eye's made out of living tissue. And you see here that we've got a lens, as you all know, that we need to focus with. Here's our pupil. This is a cut now through the eye going from front to back. And the window of the eye is called the cornea. And this is the white of the eye sitting out here, the sclera. But these tissues, particularly the cornea and the lens, they need nutrition like the rest of the body does, right? I mean, they need glucose for power, and they need proteins for reconstruction, and they need, all the different minerals and the rest that are critical for life to supply, which blood normally forms, but blood won't work. Why? Because blood's not clear. So we can't have blood pumping around. So the eye makes its own special type of blood, and it's called aqueous. And that you can see in this blue arrow right here. So this little tissue right here produces essentially a filtrate of blood. It's blood minus the red blood cells. Changed a little bit, but largely that's what it is. And it circulates, comes around, provides all the nutrition, proteins, minerals, etc., needed for the lens. And then it comes around, provides it for the cornea, which also needs it. And then it comes through the pupil And then it exits through this little area here called trabecular meshwork, which looks just about like gauze when you look at it. And then it allows for it to circulate and then goes back into the blood system. So it's think of it as a specialized blood. Now, some of you who are thinking for a bit say, well, red blood cells are kind of important for something called oxygen, right? So how in the world do you get enough oxygen to provide what's needed here for the front of the eye? Interestingly, the eye has evolved so that it can breathe. It can get enough oxygen from the air to provide that, so it does not need blood to do it. So pretty fascinating. But if that pressure goes up above normal, which usually means this trabecular meshwork in this area right here is not allowing free flow. If it goes higher, then the glaucoma process starts occurring and you slowly start losing the nerves until eventually you can go totally blind if it's not caught soon enough. So the real culprit in all of this then is what is happening back in this area, which is the optic nerve. So you can see the optic nerve represented. And what the optic nerve represents extensions, what we call axons, in association with one type of cell in the retina called the ganglion cell. And so glaucoma is all about the slow death of these ganglion cells, generally associated with the fact that the pressure in the front of the eye is too high. Now, why those correlate back and forth is still the element of a lot of research, but we clearly know if the pressure gets high enough, everybody will get glaucoma. But it's often difficult to know at what level it occurs, and we know plenty of people even at normal intraocular pressure. So ranges we know that most people have is enough where they can have glaucoma. So that's going to be part of our overall mystery we're going to be talking about here. So what does glaucoma do? Because it slowly robs you of your peripheral field, early glaucoma is usually not noticeable to most patients. It's pretty rare for a patient to come in and symptomatically tell you they have glaucoma and it's never been detected. Now, sadly, if it's that bad, then it is very advanced. Now, because the nerve itself has got what we call plenty of bandwidth, there's plenty of information that can be provided. It turns out that you can lose about half of those individual nerves, those axons that are coming before we even can detect glaucoma. So there's a lot of reserve. Then you can start losing probably another third of that or so. So you're down to about a third of the total that's available before you start getting, pretty obvious defects that can somewhat are noticeable. But sadly, each incremental loss after that, each little small loss is increasingly more important where you get snuffed out areas of visual field. And that's what you're seeing over here. So here's a patient that's been monitored over time and looked at multiple different ways. And the black areas are places they can't see. Now, this little area right here, notice that's all the way through. That's the optic nerve. We all have a blind spot, believe it or not. The brain hides it from us, but there's all kinds of tricky ways that you can go in and with your finger find out that it disappears. But we all have that's right where the optic nerve goes out. There's no vision seen where the optic nerve comes and gone or is lost as far as the eye. But notice now this is sitting up, and this would be up near the nasal area starting to be lost. And now you can see this is progressing. Now notice that a lot of the half of the field is being lost. So this is going to be a noticeable defect for patients. Now, it's not usually quite as noticeable as it's superior as it is inferior and the up above rather than down below. But you can see over time. And even this is going to be a problem for some patients. So we want to catch this much, much earlier. We don't want to progress. And that's the critical area of what we have to do. Diagnose it before patients know about it. Pick it up early, treat it early so we don't get those kind of black areas in our vision. So how do we do that? Well, one was the visual field we just showed you, and that's still a tried and true method that is monitored. Any of you who are being looked at for glaucoma have already had that kind of visual field done. This is a newer technology. And it's fascinating that by using visible light and using computer programs by how it bounces back, we can literally go in And we can look and see what's happening to that ganglion cell layer. And we can measure exactly how thick that is. And the overall thickness that you can see is this little black line going along, and we can see where it is all the way around the eye. And what's it's saying is there's an area that's up above and down below, these little red areas here, where we're starting to lose too much. That layer is starting to show likely damage. Now, because we vary enough, a single test doesn't tell us everything we need to know, but it's progression over time that's really important. That we see a change that's getting worse and worse as time goes forward, which is something you can see here and here, that there's more area of damage that's happening in this particular patient. Then you know you've got to deal with glaucoma, and you've got to do more to try and stop progression. So it's not enough to treat it. We've got to monitor it. And if the treatment isn't getting us a cessation, a stop of progression, then we got to do more in order to take care of it. And so that's why it can be such a difficult disease to treat. As far as overall size of glaucoma, second leading cause of blindness in the United States today. In the developed world, this is the second leading cause of blindness. So we're talking millions of people in the United States who have glaucoma. So you can see what this means is that your peripheral field for you starts to disappear. And then soon you'll get chunks of area inside, like we saw with that one patient, are disappearing. And if you let it go long enough, you have what's called absolute glaucoma. And that is stone cold black, everything. Now, this isn't legally blind. This is stone cold blind. So that can be an awful outcome, which clearly we need to prevent. So this is the second cause of blindness in the developed world. Over 100 million worldwide. Here's the two important factors. And this is the United States. I'm not talking Sub-Saharan Africa on this one. 50% of those who we know have glaucoma do not know they have it. And we've done that by these very large population studies where we pick it up regularly. And we realize half the time we pick it up and patients had no idea. Why? Well, it's not enough to bother them, right? They don't see it. Kirby Puckett, the famous baseball player, he picked it up because he had a fastball come in and just disappeared on him. And it happened again, and he said, I better have my eyes checked. Now, you know, a lot of people don't get their eyes checked regularly. He had very advanced glaucoma. He no longer could play baseball. So we don't want it to be bad enough that people can notice it. But if they're not being seen regularly, they should be getting treated, and they are going to get in trouble. They don't know it. Sadly, because it's often hard to determine exactly when glaucoma occurs, and glaucoma often doesn't occur even in those who have mildly elevated pressure, that half of those are misdiagnosed. So this creates a big dilemma for us in trying to follow patients and in public health, and saying that those that need to be treated are treated, and that those who have the disease get it diagnosed so that they can be treated. Now, let's just look what this means then for places like Sub-Saharan Africa. Anywhere in the world, really, where there's limited amount of professional care. We feel that everyone, at least every other year as an adult, should be evaluated and have their eyes looked at. And the main reason we want to do that is glaucoma, because that's the silent thief. But any cause for loss of vision, this is looking at all the other potential problems, cataract, retinal diseases like macular degeneration. But typically all of those are going to cause symptoms. Glaucoma, remember, no symptoms until it's a problem. And usually that means that it's going to be difficult because you've already had a lot of damage. Well, people in Africa don't even have an opportunity to see a regular physician, let alone an ophthalmologist. And we are working with these areas, and we know that often there may be one ophthalmologist per 3 million people. There's no way they can see all those people, even if people had access to them. Further compounding it is that people of African descent, and true in the United States as well in Africa, tend to get glaucoma much more commonly, and it's much more severe than Caucasians. So glaucoma is a huge problem, and it's usually not detected until people have already lost a lot of vision. And that's one area where we do often see absolute glaucoma, where the eye is completely blind. So that's a big problem, because the traditional way of picking up early, treating it, and then monitoring it carefully just is not going to work in a big part of the world. So what do we do for glaucoma? The first line of treatment are drops that lower the pressure. This particular drop, and there's several other in the same classification, latanoprost, is far and away the most common. It's a very powerful pressure lowering drop. And the nice thing about it is you only have to take it once a day just before you go to bed. And it works in a lot of patients, getting the pressure low enough that progression no longer goes forward. But you never have to stop monitoring patients to make sure that this is enough. And there are a host of other drops can be put in place, but it gets to the point where just the number of drops are a problem. Plus, people are putting drops all the time for a problem that they don't even know they have. And so it's hard for people to continue putting those drops in. And so being really willing to do what is said on the drops is also a big problem. And a lot of glaucoma that advances is because people aren't taking their drops. And so that's a reason why we often approach it in other ways. We can do a laser treatment. And so let me just help orient you. So here's the cornea. That's the window to the eye, right? You can see that what's happening is that there's a laser beam and it's going back, and this is right at what we call the angle. Remember that stuff I call trabecular meshwork, like meshwork? And here's little laser spots that are being put into the trabecular meshwork. What they do is they contract the meshwork, tighten it down, and that allows the pores to open up so more fluid can go out. A laser treatment often doesn't last forever, but it often is a step where people are progressing, maybe because they're not complying. You know, patients aren't likely to say, yeah, I'm not taking your drops, but it's not working, so that you don't need to put drops in, at least for a period of time, or maybe a regimen, instead of having to put multiple drops in multiple times a day, you can go down just to one a day. So that's one element of treatment that we have beyond regular drops. The next thing we can do, where clearly nothing's working and vision is continuing to progress, is surgery. Now, you're looking at what looks kind of a blister. Do you see this funny looking thing up here? We call that a bleb. And what's happened is, and you may not see it very well, but there's a hole in the peripheral iris tissue. So the pupil is sitting down in here. And this is literally a hole going from inside of the eye back up, and the fluid, the aqueous, is able to percolate through that hole underneath the lining of the eye called the conjunctiva. The beauty of this is you can lower pressure often quite dramatically. And when it's done, it's done. And so this is one way to try to control pressure. But there are also a lot of other problems. You lower it too low, and the tissues of the eye will swell, particularly the retina. And if you have it below the venous pressure of the body, then you can imagine blood can come the other way, and you'll get blood inside of the eye. And that's not consistent with being able to see, and all kinds of other problems happen. So it's kind of a Goldilocks problem. You need to have it not too hot, not too cold, just right. And so that can be a problem. This tissue will sometimes scar off and no longer work any longer. And here's one of the big ones. If you just get simple pink eye conjunctivitis, and if it's a bacterial conjunctivitis, there's direct access from the surface of the eye through this tissue into the inside of the eye. So you can get an infection inside the eye and lose the eye. So it's something that we have to do. It's still critical, what we call a filtering procedure, where nothing else has worked in regards to helping patients in what they're doing. But clearly it's had its problems and complications, and it's something we would like to avoid. So that brings us to the whole new field, and that's these microsurgical implantation devices. These things are incredibly small. So this is one of the first ones that's developed is down here on the bottom. And this, you pop it in through the trabecular meshwork out on the periphery. This is so small, it fits down in that area. It just looked almost like a little, pinhead if you were to look at it. And you put it in, and this pops in. like a valve. This holds inside the tissue. And that means from the inside of the eye, the fluid can come through here and then make its way through the trabecular meshwork and then bypass some of that resistance. This is a similar one, only this gets inserted along in the trabecular meshwork, kind of circular around in the circumferential eye around the eye. Fluid comes here. So these are now simple ways, and you can insert these with just a little simple incision on the cornea. You don't have the big surgery like we do with filtering procedures. And this is the most explosive area in glaucoma treatment today. This is a means, and you could imagine, and you're talking about in the developing world, that the whole story there is going to be surgical, because they're not going to be putting drops in the rest of their eye and being monitored. You want, as much as possible, a one and done approach to disease for all of those suffering from glaucoma under those circumstances. Now, with glaucoma, we know that it runs in families, and we know that there's clearly got to be genetics associated with it, but the field has not been very successful to date to really be able to discover the genetic linkage. In fact, it's suggested maybe we can explain up to 5% of glaucoma from the genes we've discovered so far. We know there's got to be a lot more out of there. Now, because half of known cases progress in spite of our best treatments, so even if we lower the pressure as low as we can, including surgery, we still have half who continue to progress. And genetics research, we are having a hard time taking that next big step forward. And this is a classic problem we call garbage in, garbage out. That's what GIGU means, is that you base your overall genetic research on people diagnosed with glaucoma versus those who are not. But if half of those diagnosed with glaucoma actually don't have it, and many of them who you think are normal actually have glaucoma, then trying to find a genetic defect with those two poorly differentiated groups becomes extremely difficult. And sadly, that's been the big problem with the field to date. So with all that background, what do we want to do about it? Alan Crandall is just a giant of a man, and a giant in regards to his impact at Moran Eye Center and all that he did. I've known Alan clear back to high school. We did our pre-med together, medical school together. The first person I called when I decided to come here over 42 years ago was Alan, who was then on faculty at Penn, back in Pennsylvania. He joined 2 years later and was a pioneer in the field of glaucoma as a glaucoma specialist, and a pioneer in really all kinds of complex anterior segment procedures. But even more than that, his heart and soul were in the developing world. What can we do to help those people who have really no hope, and so much of their disease is totally treatable and preventable? So Alan tragically passed away after difficult surgery with complications last fall. And because of that, we are starting the Alan Crandall Center for Glaucoma Innovation. And we're going to use this as a means to change an entire field and commemorate this incredible individual and all that he represented. We all miss him dearly, continue to this day, even though we're approaching a year since his tragic death. But in this way, we will never forget him, and we will never forget the work. And the work and accomplishment here will then be just continuing kudos to Alan and his incredible presence. So in thinking about who we could get to manage this, Alan had always talked about that the one person who had trained with him as a fellow was Ike Ehmet, who is the father of these microsurgical devices. He's the father of all these new approaches. The Ophthalmologist, which is a publication out of London, England, annually likes to talk about the top 50 people who and the innovation that they're doing in association, or the top 100 in the world in vision. And this includes people in industry and research in all walks of life. Last year, they ranked him as the most influential person in the field of vision in the world today. So the fact that he was trained here at the Moran Eye Center and his incredible work, he's at University of Toronto in Canada, is that we've asked him to be our director of this Alan Crandall Center, and he's graciously accepted. We're in the process of getting all this transferred and put in place, but we couldn't be more pleased that this amazingly innovative individual who was trained by Alan and a dear friend of Alan and a dear friend of mine would step in. And we're going to give you a little taste of this incredible individual who will help us lead this effort to change the field of glaucoma. So this is a little bit from Dr. Ahmed. He always likes to, present as a bit of a renegade because he's fought against the general current to do things and such has been amazingly innovative. So let's get this started and you can get a taste.
My name is Ike Ehmet. I'm at the University of Toronto. I practice cataract and glaucoma surgery. Interventional glaucoma, or IG, has been a big concept for me. And this isn't a specific technology or a product. This is an attitude. Being proactive in disease, managing earlier, more aggressively, and not necessarily with added medications, but with interventional approaches. Now, why do I favor interventional glaucoma in terms of the approach? I think that medications and passive watching is helpful for some patients, but too many patients under our watch still progress, still get worse over time. And I think the need to intervene earlier, meaning getting lower, doing it safer, and doing it earlier, I think, hopefully will lead to less patients progressing and less need to do more aggressive therapies. So I think we're in the era of interventional glaucoma because of some of the newer diagnostics, catching people earlier, because of the newer technologies allow us to intervene earlier, for example, like MIGS and other devices surgically. So that's kind of what, to me, what interventional glaucoma means. I think the field's evolving with their understanding of how tough this disease is to treat if we don't get a head start on it. So, MIGS, of course, was a procedure set that was designed that fits well within the wheelhouse of interventional glaucoma. And the way it's transformed glaucoma is it's allowed us to treat pressures in a surgical manner without relying on medications. This is important because compliance and adherence are still major problems. And typical traditional surgical approaches, of course, have early and late complications. So I think what MIGS has brought us is the ability to address these issues in a less invasive way. And I've always felt that elevated pressure, at least, is best managed surgically. The problem is a surgical issue. Let's treat it surgically and do it in a safer manner. I think this has allowed us to do it, especially when it comes to combining with cataract surgery, and especially for patients that have earlier disease where we're not willing to take the risks of more aggressive options. 10 years ago, we only had really one MIGS procedure. Now we have over 12 different options. I think one of the challenges is to understand which option does best for which patient. We also realized that MIGS, as much as we enjoy the safety of MIGS, we still are wanting for more efficacy. So better understanding, where does MIGS fit, what particular device fits what particular patient, and how do we maximize the IP lowering, I think is where we still are working on options. I think we're going to get there, but it requires a better basic understanding of what these devices and procedures do. We have options, though, allowing us to go inside the eye or outside the eye. But it does allow us to tailor the procedures based on pressure targets, whether we're going internal, canal-based, or whether we're going externally with subconjunctival-based. So although we do have some barriers, I think the data is coming out more and more now, efficacy-wise. The safety, I think, is been well described. We're also thinking about quality of life, understanding the impact to our patients, which is beyond, of course, just a simple IOP number.
So anyway, that gives you a taste for Ike Ehmet. I wanted to show you a surgical video. Turns out that Dr. Ahmed is just amazingly gifted in doing complex procedures that very few people, in many cases, he's the only one I know who can do some of these things. But I was overruled, so you don't get to see a surgical video. I guess it was felt to be too bloody. It might ruin your appetite, but I would love to let you see some of the incredibly complex things that he has pioneered as just a real cutting edge individual in every way. And we couldn't be more pleased that we were able to attract this international star who has an international practice due to his fame here to the Moran Eye Center. So we're going to have several initiatives. Initiative 1 perfectly fits with, here's a picture of Dr. Crandall doing surgery, glaucoma surgical therapeutic. So this is what Dr. Ahmed talked about. He's really the father of MIGs, these new glaucoma devices. And so this has to do with developing the new and innovative MIGs, new ways of approaching. I just was working earlier today with an executive who works with Dr. Ahmed and is now going to be working with us on a new device where you can use a laser after it's inserted to control how much fluid escapes from the eye. And that's been a huge problem in trying to make sure that you've got, not too much, but enough. And now a laser can be used to control the amount of flow, and you can control it wherever it's going to be. That's going to be a huge breakthrough. That's just one of many, many. And we're also going to be working very, very closely developing and working where we can have our own glaucoma drainage device that will be incredibly inexpensive, can be used in the developing world to get to as close as possible as a one and done. Find glaucoma early, be able to then and surgically treat it so they don't have to worry going further. So that's the dream of Initiative 1, and certainly a very important one indeed. Glaucoma surgery complications are very real. You'll wonder looking at that, what in the world am I looking at? So this is a common problem after glaucoma, usually because the pressure was too low early on that it bled underneath the retina into what we call the choroid. And so these two big things are just really big blood blisters. And you could imagine the damage that can do. Often, even though you evacuate the blood and pull it back, and the vision never comes back to normal. And there's a whole long list of complications that can happen during this. And so these new devices are going to avoid all of that. And we're particularly excited about that. So Initiative 2 is glaucoma transitional, actually should be translational research. This is figuring out other new and better ways of approaching glaucoma than we're currently doing, getting at and understanding the basic process in a better way. We already have a star in this field, our own David Krizai, a picture you see here, one of our endowed professors who has done brilliant work in glaucoma, and he's figured out a mechanism whereby pressure signals these ganglion cells to die. Yeah, it's the holy grail of glaucoma treatment is neuroprotection. We have people who have elevated pressure who never develop glaucoma whatsoever. And so we know there's got to be a variation. He has a process that we feel with the medicine that he's been able to develop and working with our own organic chemistry people down here on Lower Campus. And we're working hard now with a group to go into clinical trial with not only one that's going to be a powerful new way to lower pressure in the eye, but we think will be protective, will actually stop the process, even though the pressure may be elevated, and particularly in those who it continues to cause death to the ganglion cells when the pressure is normal, to help block that process. We're very excited about it. And that's just the start of a whole new set of things we want to do in association with neuroprotection. Here's another one of our brilliant researchers, Brian Jones, very innovative, has done many firsts in understanding retina tissue and what's happening with it. And part of where we are working with him and his work and effort is regeneration of the optic nerve. And I told you, once you lose any of the nerve tissue, it's gone. You can't get it back again. But there are animals that can get it back again. There's a ground squirrel that turns out that Dr. Jones has looked at, that they go into such deep hibernation, the entire interretinal process, including the optic nerve, dies off every year. They wake up stone cold blind from hibernation and regrow the whole thing. How do they do that? They've got a system even certainly as complex as ours. We think even a little more complex. So we got to figure out those secrets. And this will give hope not only to those who have lost their vision from glaucoma, where we can get it back again. But people who've lost vision from diseases like multiple sclerosis, from optic nerve trauma, a host of other indications where that can be there. So that's another area that we want to pursue and move forward, this whole area of optic nerve regeneration. Initiative 3 is global glaucoma care. I've told you that in the developing world, the whole field of glaucoma is a disaster. These patients are not getting diagnosed until it's very advanced. And then our typical way of treating it is not going to be effective. And our surgeries often lead to too many complications. The odds of getting simple conjunctivitis are too high, and they're going to lose their eye. So there's got to be a much, much better way to deal with these people. And it's a particularly big problem, as I mentioned, in Africa, in that people of African descent are more likely to have it and get much more severe glaucoma. So our own Craig Chaya, who's the co-medical director of our Moran Global Outreach Program, and his entire career that he wants to have and focus is in dealing with the developing world problems, is going to be the leader of this particular initiative. And it's a simple and complex goal that we have. Number one, we gotta diagnose this earlier. We can't wait until people say, wow, I can't see much out of this eye, because it's just too far. The horse is out of the barn way too often. Our thoughts there is that we got to have simple devices, potentially maybe apps, other simple ways, and that we train, like we are training people in these small villages to detect cataracts and to set it up, is that they're able to, and fit glasses, and they can also start looking and detecting glaucoma at an earlier level. And then it's going to be a surgical treatment. And we think it's going to be one of these drainage devices where it's a minimal complication, quite simple to do. And under most circumstances, it's one and done. Those who know it, hopefully will be able to at least get follow-up, every couple of years or so if it's not working, but something much better than what we're doing now. Essentially, we're losing the battle in glaucoma, particularly in Africa. So a little bit of the challenge. I mean, these are just examples of some of the nerves that you typically see when patients come in Africa. All of these mean there's very little vision left, and they're not going to go and get their eyes regularly checked when they are not having a problem or difficulty. So sadly, by the time we see it, it's exactly the kind of pictures you see there. With all of these, vision is substantially gone, and at this point, not recoverable. So that initiative 3 then is early diagnosis and then surgical treatment, and we'd have to do it where the treatment would be, in the element of a device for a dollar or two. It has to be extremely inexpensive. Fortunately, we have our formal partnership with Aravind in India, which is the largest such overall service providing care for those without the ability to pay. And they have a very innovative set of manufacturing. They produce an intraocular lens that's available for just a couple of dollars. It's really high quality. And so we think that is going to happen, and that's going to be one of our important initiatives. Then initiative 4 is a better understanding of what is really happening. Why does glaucoma occur? Why do some people have elevated pressure and never get glaucoma? And why some have normal pressure and have bad glaucoma? And so understanding what is causal there. And there's clearly an important genetic mystery that we should be able to determine. So Greg Hageman is going to be a very important part of that. Some of you may know of him. He has been a true pioneer in understanding macular degeneration. He's our John Moran Presidential Endowed Chair, and he's Executive Director of the Sharon Eccles Steele Center for Translational Medicine, which his entire focus is getting breakthroughs rapidly out into clinical care. And that's been so exciting. We have a treatment for underlying macular degeneration based upon incredible translational science that Greg and his team have put together. And we are very close now, the final steps to moving into human clinical trials. We really hope that early 2022, less than a year, we will be there and we'll be starting to do some of this work. So what did he determine? How did he was successful? Here's macular generation. Now remember, here's the nerve that's damaged in glaucoma, no excavation there. But look at this. You see all that right there? That is retina that's just gone. There is no retinal tissue there. We call that geographic atrophy. This is very advanced macular generation. That patient is clearly legally blind and be very handicapped. This is what bad macular degeneration looks like. And it is the leading cause of blindness in the developed world, certainly in the United States. Again, we're talking millions of people with this particular disease. What Greg Hageman was able to do is by carefully following patients, by making sure that he had very pure groups of those with macular degeneration and what we call supernormals without, getting very fresh human tissue after death, where people in the studies were willing to donate their eyes, been able to determine that there are 2 genes that largely cause this, and there are variations of these. And the new treatment we have is we also found there are people who are protected, and it is turning those who have a bad gene causing their macular degeneration to a protected variation. It could be a gene therapy. Really very, very sophisticated, but amazingly successful work. And we're very excited about that. So you want to repeat the same thing with glaucoma. The work that we want to have Greg Hageman do in association with this now is the same thing. Get very pure groups of glaucoma. Absolutely no question they have glaucoma. And very pure groups of those we absolutely do not have it, with very intensive imaging and very clean, and then start comparing genetics. We've already looked at some and found 2 new genes that have never been proposed before. And we're getting those confirmed as we speak, and they're more important than all the genetic discoveries to date. So I know the team can do it. And we find causal mechanisms, some of which I think Dr. Creasy may be on, and we'll find the genetics, I'm sure, related there too. That'll give us whole new ways of treating this and preventing it, so that it never becomes a problem even before there's any loss of ganglion cells in the retina. So conclusions. We can tell you it's a mysterious disease, and you want to diagnose before the patient ever knows about it. Too many diagnosed patients still go blind. Remember, I said, even those treated, half are still progressing. Now, at a slower rate, but they are progressing. So too many people are ending up, and that means it's the second leading cause of blindness in the United States. We talked about the developing world, especially Africa, because of their likelihood of developing glaucoma, and it's bad glaucoma. And so that's this whole new Alan Crandall Center for Glaucoma Innovation, way to honor this amazing individual, but to make a difference in a disease that needs some big breakthroughs at this particular time. Our recruiting of Dr. Ahmed as an absolute leader in the field, particularly new ways of surgically treating this disease, is just a testament of the support that he's willing to make this major transition to help us in this overall effort. And we will, through this mechanism, I'm not saying possibly, we're going to find causal mechanisms. We're going to find new ways to treat this disease that are going to get at less people going blind, more people not having to worry about this awful condition, and that we can indeed provide more hope to more of the world from this horrendous, visually blinding condition today. Thank you very much. All right, I'm open to questions. So I've got one here. How can people support the work and research at Moran? You know, the Moran Eye Center exists because there are many, many people who have been willing to see and understand the vision of what we've tried to do. And it is through gifts and donations that we have this incredible edifice, that we've had the research program we put together, and that we've been able to excel at the work we do. Those who are able, any who are willing to give and support with donations, 100% of everything donated goes specifically to whatever's desired. And if it's glaucoma, you put it there, and there's not going to be a penny going to anything else other than our pursuing this work. We already have a couple of significant donors that we're approaching, and who've committed. And I'd like to have announced those, but we can't quite do it yet. But there'll be people that people have heard of and know about. But we are going to make sure that we have the resources that we can move forward. Now, also, this study is going to get up and be launched. And so even if it's not macular degeneration, we're going to want more people that'll come in, and it's going to be important to have normals as well, and determining who's a supernormal as those who have the disease, both for glaucoma, macular degeneration, and the other one that'll be coming soon is diabetic retinopathy, because that's another huge problem that's the third leading cause of blindness in the world today. All right, come on. Those of you want questions. What are the best preventative measures people can take to protect their eyesight? So there's a lot of different areas where we can do things to help. The most common visual problem right now is nearsightedness, myopia. And it used to be felt, well, that just kind of develops, not much you can do about it. We do know a lot of near work, in particular in poor lighting, holding things close to the eye, and in those who are genetically susceptible, that will result in myopia. And so making sure that kids get some outdoor time, for instance. There are even some drops that are being developed to help slow this overall progression. Overall for macular degeneration, a good diet rich in fruits and vegetables. Exercise has been shown to be important. For cataract, it's avoiding sun exposure. That's also important. We're not aware of any preventative measures yet for glaucoma that people can do. It's pick it up early. Go get your eyes tested. All healthcare professionals that are involved in examining the eye know that they need a screen for glaucoma. And that's one of the important things. So, and certainly by the time of 65, an annual exam, you want this early. You don't want this picked up where you've already got symptoms. So talk about how can we find these open trials, specifically Dr. Ahmed. We're in the process of getting that all up. So all I can say right now is stay tuned. Anytime you've got somebody from another country, you're dealing with, visas and others, but it's all coming together rapidly, and you will soon hear these announcements. So stay tuned on that one. Any other questions here? What is the most frequently treated disease here at the Moran Eye Center? Overall, the most frequently would probably be either nearsightedness, farsightedness, or astigmatism. So that'd be fitting glasses. That's just true in the visual field in general. Most people, I don't necessarily see that as a disease, but it certainly is the most common problem that people deal with. The second by far would be cataract. If you live long enough, everybody develops cataract. That's where the lens inside of our eye starts losing its clarity, and that just is going to happen. And often it will end up that the clarity is down enough that we have to do surgery to remove that hazy substance and then put an artificial lens in its place. And we end up doing thousands of those a year at our place, and then followed by macular generation, which we can treat when it's wet very successfully. And we're going to an underlying treatment as mentioned. So those are the common ones. Lynn Ward, who's our director in regards to all the outreach that we do, pointed out that for more information, how to support the Moran Eye Center, she's pointed out, you can call 801-586-9700 or moran.info@hsc.utah.edu. And those of you who've got chat, you can click it and see that. Then she pointed out that the number is 585-9700. So let's correct that typo. Yeah, 585-9700. Or you can go online and it'll give you all that information, and it'll tell you, where you can move and do and help with support in everything that we have. Any other questions? So it's a question about prevent macular degeneration using red light wave therapy. I am aware of some of the work done, and there's also some work in regards to low-level laser for those with early macular degeneration as a means of treatment. You know, it's always hard when you hear stuff like that, and I will just say that the science behind this, I think, is not well developed. And knowing that there's inherited genetic defects that basically determine macular degeneration. Yes, there's a nurture element, and we can see that it comes on less early and potentially less severe. It doesn't progress as fast through elements of diet and exercise. But the genetics, particularly where it's bad genetics, pretty well decide what this disease is. I'll just frankly say I'm very dubious that the red light therapy is going to be effective, and I don't see any solid science at this point. I'm always open-minded. You know, if people can show better science, then I can accept it. But it really doesn't fit with what we know, and so I think it's a really, really long shot. The laser, low power, specific wavelength laser treatment. I think there's a little more evidence of that. But at this point in time, I don't see enough evidence to where, you know, it's what I want to do. And frankly, what we're getting at is a very underlying molecular mechanism. And so the turning a risk profile into prevention, so that people who would have gone on and catching it very early with macular degeneration go on and clearly have gone blind, and just simply prevent it completely from happening based upon the known underlying mechanism. That to me is a much more important way to go forward. It says those are all the questions. It says please wrap up when you are ready. All right, I'm ready. Are you ready? All right, we're going to wrap it up. Can't thank you enough for all your support of the Moran Eye Center. Can't thank you enough for all the amazing people at the Moran Eye Center and the great work they do. I'm the luckiest person in the world. I get to sit here and see all this work done. Sadly, I often get credit for work that really is all of my colleagues. But I love the fact that differences are being made, people are being helped, and that hope is being given to those who are without hope. And on that note, and with all of your thanks and support, we'll sign off. Thank you, everybody.